Good morning, everyone. As Bernard said, I'm working here in Belgium as a rheumatologist, mainly clinician. And I will present you now, my task was to present you some practical information about synovial biopsies and the procedure itself. We'll talk about asepsia, how to prepare your hands and the patient also. Some information about anesthesia, what you do after the procedure, about the entrance hole in the joint, the pain management, and the corticosteroid injection that you can do after biopsies. And finally, we will talk about the learning curve of this technique. So, for asepsia, we have learned in the medical studies how to prepare our hands before surgery, entering in the operating room, but I thought it might be useful to remind us some definition and maybe to make an update on the recommendation of the World Health Organization about asepsia. So what you do before entering the operating room is called surgical hand antisepsis, or surgical or pre-surgical hand preparation. So the objective is to eliminate transient flora and reduce transient skin flora. And we will see after with one product that the antiseptics that we use often have a persistent antimicrobial activity after the procedure, which is quite good for us. Two definitions that might be useless for English native speakers, but for non-native English speakers, it's interesting. So you can scrub your hands with water and soap and a brush, or you can rub your hands only with a waterless alcohol-based hand rub. So in clinical practice, we all use the hand rubbing with the alcohol-based solution, or with the outpatients, or before the surgery. We can use two products, but what is important to know, especially with the alcohol-based solution, is that it is better tolerated than iodine solution that you use with a brush, and it is as effective in terms of efficacy in lowering the bacterial load on the skin. So we have two products, as I said, that can be used and that meets the European standard 12791, which are the chlorhexidine digluconate 4% and the hydroalcoholic solutions. Other small recommendation before going on with the products is that indeed the patient that you might take off the rings, the wristband, the watches. The nails have to be short and clean, so the day after just do it, because sometimes you look in the mornings it might be too long. For ladies, no false nails and no nail polish. Well, everyone knows it, but it's sometimes it's good to remind it. So I will present you now the recommendation of the World Health Organization about asepsia. It's in two steps. It's very easy. It's much simpler than before, I think. So the first step is a simple hand wash. So you use, you may put the cap and the hat and the mask before it, but you just use a soft soap and you wash your hands. And if you follow the steps that are made everywhere in the hospital, I think, and the nurses are doing this, I think, better than us, it will take you like 40 to 60 seconds. After you take a normal paper that is not sterile, and then you dry your hands. You can go on. You can move to the second step, where you use an alcohol-based hand rub. So it's very easy, very cheap, and no problem using it. So you will begin easily with the mask and the hat by dipping your fingertips into the hands and washing, letting them a few seconds to decontaminate them. And then, well, it's a little bit of exercise, but if you begin with the right hand, you will wash the right forearm with the left hand. And you have to follow exactly the sequence, going from the wrist to the on the forearm to the elbow. And then when it's dry, you can go and do the same with the other side. So once, so it might be a little bit difficult at the beginning, but after two times, it might be very natural at the end. So once your forearm are dry, you can go on with the hands. So again, you put some solution in your hand and you wash your hands like this, following these procedures. And when at the end, when your hands are dry, you are sterile. Okay, this is really important. And then you can move on to the operating room, where you might need the help of a nurse or a technician, whatever. You may put like sterile gloves, and you may at the end finish a little bit like this with the ultrasound machine, the patient and you. So this is the patient, and we will see now how to prepare the patient. So the aim of the patient preparation is a little bit the same, is to reduce the microbial load in the patient's skin as much as possible before incising the skin. For ultrasound-guided biopsy, we recommend the chlorhexidine gluconate 4%. That is very safe and very powerful. Some words about it. It's chlorhexidine digluconate is very effective against gram-positive, gram-negative bacteria, and against some viruses such as HIV, influenza, herpes simplex. What I told you at the beginning, that it prevents antimicrobial action up to 6 hours after the cleaning. So it's quite interesting also. Another point is that when you do like when you go inside 50 times into the joint, there's no doubt that some liquid, some chlorhexidine goes into the joint. So we know that it's safe because we haven't met any problem. But there is no evidence that chlorhexidine gluconate is toxic if absorbed through the skin. This might explain also that we don't use sterile gel like it is available, because we don't know what will happen to the gel inside the joint, I think. This is my explanation. And also chlorhexidine gluconate is very well tolerated on the skin, but you have to be aware that some allergic reaction have been reported. It didn't happen to me, but you have to know it. Depending on the target joint, you may the patient may be or seated if it's the biopsy of the upper arm, or maybe lying on the bed. So it depends. Usually we have a chair and a bed, but sometimes beds can be adapted and on a sitting position. The patient has to take off the rings, the bracelet for the upper arm. You don't have to shave. Well, even if there's a lot of hair, poil, hair. And the patient should wear a mask so that he can speak easily, especially when it's a hand biopsy. So depending on the target joint, the area to wash will of course depend, but this will be maybe highlighted by the next presentation. In the next presentation, so for wrist, MCPs, and PRP, you wash the hands and the forearms. For the elbow, maybe part of the arm, part of the forearm. For the knees, part of the thigh, part of the leg, and for the ankles, NTPs, PRP, part of the leg, ankle, and then the feet. Of course, I think it's better that the nurse wear a mask and a glove. It's very easy. And the family, usually one person of the family can stay, but they should wear a mask also. You may also have this kind of setting on your table. For example, sterile drapes. You have two sizes. Usually for the upper arm, you use like small drapes. I use like 4 to 5, for example, for a wrist. But for a knee, you may use like 2 large drapes and maybe 1 or 2 small. Of course, sterile compresses, usually 150 milliliters of chlorhexidine digluconate. Why so much? Because usually you use it also, besides the washing, you use the chlorhexidine digluconate as a gel for the ultrasound the probe. Sorry. You need some needles, the biopsy needle. Ilias will show you some needles in a few minutes so that you can touch and see by your hand if you didn't see before. Needles for the anesthesia and needles to take the samples at the end of the needle biopsy. And also a sterile sheath for the ultrasound probe. So you have 2 types of sterile sheaths. You have one where you have to put gel inside, but you have another one, which I use, where you don't put gel inside, just you stick the probe, so you don't have any bubbles, and then it's very easy. So you might try also. So once you've done this, sterile, the patient prepared, you're ready to do the anesthesia. So it's a local anesthesia using lidocaine. Usually 1%, it's enough. So depending on the joint, you might use different volumes. Of course, in a MCP or PIP, 1, 2, or 3 milliliters is largely enough. For a knee, 10 milliliters can be enough. Sometimes you need like 15 milliliters. As for the maximal dose, you can be, it's all safe because if you use 10 milliliters of lidocaine 1%, you have 100 milligrams. And for a patient of 60 kilograms, the maximal dose is 300 milligrams. So you can go, even if you put 20 milliliters, there won't be any problem. Of course, you go from the skin to the synovial hypertrophy. Usually, you can just do a small skin anesthesia. Then you wait like 45 seconds, and then you can go. It's very quick. So maybe you won't ever have a side effect except if you inject into the vessel. But in that case, the patient might tell you, I feel like a numbing in the fingers, a metallic taste in the mouth, blurred vision, may have increased blood pressure or cardiac arrhythmias. But it never happened, I think, in my case. Maybe in London, I don't think so. One thing you have to know about lidocaine is that it is a safe product, but if you go on PubMed and you type lidocaine and joint, you may find like pretty alarming studies that, well, all the local anesthetic have chondrotoxicity. Okay. But I found a nice review in 2015 about this. So the main problem is not for us, but maybe for the orthopedics. You say, why do I talk about this now? Because it's the risk that the condition triggered by the anesthetic, usually used with a pump and infusion into the joint, result in a very dramatic condition, where, and especially in the glenohumeral joint, you have like a total breakdown of the cartilage in the weeks after the arthroscopy. So if you do acromioplasty in a young man, and I don't know, 2 months after he needs a prosthesis, so it's very bad. What is nice for us that there's a minimal clinical evidence of chondrolysis resulting from a single injection of local anesthetic. But I think we have to also be aware that there is a in vitro toxicity of the articular cartilage of lidocaine. We don't know exactly the mechanism of action, but indeed it might be dose and time dependent. So after the biopsies, it's very simple. You can, while you press the entrance hole with the compress as it goes. You can wash with sterile water, and after maybe 2 minutes to avoid like hematoma, you can put a small dressing on it with a little bandage that the patient can take off the day after. So usually it's very well tolerated. There's no problem, but we advise you to give contact details to the patient, even if you're pretty sure, almost convinced that there won't be any problem. But so you give the phone number of the operator or the nurse in case of significant pain, swelling, bleeding, neurological symptoms. But as Andrew Filer told you yesterday, with all the results we have, it's a very well tolerated procedure. So usually with paracetamol or ibuprofen, whatever, the patient can deal easily with the pain. So there's not much to say about this. Corticosteroid injections. There was we talked about it yesterday. There was a retrospective study of the patient-reported outcomes and safety in patients who had the synovial biopsy and with different techniques. Ultrasound guided needle biopsy, portal forceps, arthroscopic guided biopsies. And among the 524 procedures, 62 patients received corticosteroid through intramuscular injection, and 38 in the intra-articular way. And we're happy to say that there was no infection, no problem in those patients. And as Andrew said yesterday, when you do an infiltration, well, you have patients have less pain and it's less swollen. But as the biopsies are done in a research program mainly, you might never use infiltration because it's against the protocol maybe. You may use depomedrol, triamcinolone acetonide, or triamcinolone hexacetonide. It's better to use the ultrasound guided way, so you're sure to be intra-articular, really inside the joint. But what I've observed is that in small joint, maybe not in the knees, but sometimes in MCP, but mainly in, sometimes in wrist, but mainly in MCPs, that when you inject, all the product goes out. So it's a very small joint. The hole is very big, so just inject and put your finger. But it works. So if you try it, don't be shocked. The final point was the learning curve, very important. Frances told you a little bit about this yesterday, but we will go a little bit more in details today. So she told you, the validation of the ultrasound-guided synovial biopsy as a reliable technique for example, randomized control trials is very complex, and it's a long process. It has to go through the Overarching filter to have a full validation. And besides the validity of the technique, what she told you yesterday about the truth, the discrimination, the learning curve, defining the learning curve was part of the recommendation for validation since the beginning. So I will present you now. Oh, no, and so of course you can try on cadavers. I did this a few times, and 2 times, and I know that Stephen Kelly did a course on corpse. It can be useful at the beginning, but you know it's very stiff. The joints are very stiff, and all the structures stick together. So it's after 2 times it might be useless. And I remember I was in the room with like 30 cadavers with no light. It was fantastic. No. But maybe you can ask. I have asked the anatomy teacher to let me use his corpse, and it was nice. So indeed, the ideal training, as Francis showed you yesterday, is this one. First, you have ultrasound and ultrasound guided injection training for small and large joints with supervision during like 2 or 3 months. Then you have the observing time, where clinician training at least observe 1 or 2 procedures for each joint. And then you may begin the supervised procedures. I will present you now the work of Alessandra Nerviani, who works in the lab of Professor Pizzalis. It's part of the thesis. And I will present you the data of their learning, because it's quite close to that ideal training, what they're doing in Mile End Hospital in London. And the question that Alessandra raised, that how to assess learning, because it's sometimes difficult to say this doctor knows how to do a biopsy, or even after, do I do good synovial biopsy? Is it synovial tissue? So there are several variables that could be considered, but we will focus only on the 2. The histological assessment, because now I think it's the best way to say that it's synovial, to claim the synovial origin of the samples, and we'll give also information about the duration of the procedure. So she evaluates retrospectively the performance of the learning curve of 5 individuals that were clinician in training in Mile End Hospital. They did from 23 procedure to 85 procedure, and Alessandra divided the training into 6 phases, every 10 biopsies. And I present again the table she showed yesterday, that at the beginning, 48% of the biopsies were positive. In there, as the positivity of the biopsy of the presence of gradable biopsy is defined by the presence of intimal layer, or CD68 in the sublining, or typical synovial structure in the sublining. And
Lawrence, I think it's important for the people who are seeing this data first time to clarify one point here, because otherwise you might get the wrong impression if you say 48% of the biopsies are positive. Now that doesn't mean that. It means that over the whole fragment, 48% are gradable. So you still have a positive biopsy in those patients.
yes, but
Because some people get the wrong impression.
yes, but it's you have to assess the learning. So even if we know it's when you do the biopsy, you know it's a synovial tissue. If the pathologists don't find the typical structures, it's difficult. So
sure, but even in those 10
yes, I agree. Yeah.
52% were positive. Okay, so of those fragments. So the biopsy procedure, even at the beginning, was a positive biopsy. The fragments that you were getting, they were not always good as you improve with your training, but you still get some good fragments out of your first biopsy. So don't be put off, all right?
No, but don't worry. But in that, to go with you, I will finish. And at the end, after 50 biopsy, where you can be maybe called not an expert, but an expert in fully trained, this proportion rise to 62%. But what is interesting is that there's a very huge variation on the positivity, 29% plus and more. So we will give maybe an explanation in a few slides. What is nice also is all along the training, you can see that the duration decreases from 50 minutes to 30 minutes after 50 biopsies. This is quite reassuring also. We'll go now for my own experience, because this was an ideal training with a supervised procedure, but you may also don't have the opportunity to have the supervised procedure and go from an observing time directly to the unsupervised procedures. So indeed, I went 2 times in London, and then I had the chance to have Ilias for the 2 first biopsies, and then I was on my own. So it was kind of difficult, but on the right side of the slide, you have this diagram where you have the proportion of positive biopsies, gradable biopsies, in the first year, in the second year, in the 6 first months of 2017. And roughly, after 1 year, I had like 55% of positive biopsy, meaning that the pathologist could see the intimal layer. And after 2 years, 60%. It might be a little bit slower than with the supervised procedure period, but at the end it's quite, it's almost similar. I have discussed this with Alessandra, and I think even if you don't have a supervised period, but if you have regularly the opportunity to do biopsies, and that was my case, every week I had like 1 to 3 biopsies, so with the time you get used to it. But if you have only 1 biopsy a month, it might be very, very difficult without supervision. And one parameter that might explain the differences between the students within each phase might be that there's another parameter that is not put here, is the ultrasound, pre-biopsy ultrasound grayscale score of the target joint. And of course, for me, when I had like grayscale score 1 biopsies, MCPs or wrist, the pathologist could only find an intimal layer in 35% of the samples, and with the grayscale 3 score, it was 88%. So at the beginning, if, for example, if this student, he was like 80%, he might have only had a grayscale score of 3, and this one maybe had the bad luck to have only low inflammation joints to biopsy. So it might be good to also to put this into the learning curve, but it might be more difficult and tricky to analyze. So
the data should be available.
Yes.
Because the ultrasound score for synovial thickness and power Doppler is done in each patient, in each joint, which is biopsy. Mm-hmm. You do the same, presumably. So
but from your comments, then the outcome there is a bit confusing, because even with 50% gradable fragments, you might have a fully achieved and interpretable procedure then. So maybe the outcome could be the number of biopsies in which you have at least 4 gradable fragments to perform your analysis. Maybe that would be, and then you would reach 100% after 10 procedures, which is a bit more reassuring in terms of visibility than 50%. I mean, I just got that when I was hearing the conversation you had, Laurent, and you. But maybe another way to formulate the outcome would be how many gradable, how many successful procedures did we get from like 50%, 60%, or maybe even 100% at the beginning to 100%?
I agree that the point of presenting the data in this way was touched upon, in fact, by Lawrence earlier on, about if you have only 4 biopsies which are gradable and useful, then what do? You can do only the histology, maybe,
true, right.
And not the PCR and not the other analytical tools that you may wish to have. So I think it's important to present the data in both ways, but I agree philosophically, I always like to present data with a half full glass rather than a half empty glass. So that's why it is to be.
Excellent.
Because no, but when you do the biopsy and at the end the pathologist said
Yeah, exactly.
normal tissue, you'll so.
So I think it's useful both ways.
Yes.
But maybe we could do the same, but with the grayscale score, because we will see maybe even at the first phase that with grayscale score 3 you have like 100%.
That's a great suggestion, Lawrence, because I think it would be more informative in providing another figure for the paper for a start, but more granularity for the interpretation of the data.
Yeah, because
You're
this
right.
is
You're right. Great idea.
really bad for us for the procedure.
Do you know what part of the failure corresponds to the ultrasound technique, and what part corresponds to badly
well, at the beginning, it's a more technical problem, I think, from the one who's performing the technique, because you don't know the angle of how to put the needle. So maybe the 10 first biopsies, the problem comes from the doctor. And at the end, it might be more related to the type of joint. For example, in some protocols, you have to do biopsies of not swollen joints. So you have to repeat a biopsy on an MCP5 that is not swollen, so it's, you know, it will be bad. So.
And the ultrasound performance is the same, there's no problem with that. They're looking for the exact point where the ideal location to take the sample.
No, this is,
no.
Maybe I told you at the really beginning, but after 10 or 20 biopsies, it's no problem. Okay, to conclude, so it's easy because we have clear recommendation for Asepsia, especially for you and for the patient. We have 2 products that can be used, the chlorhexidine glycoconate and alcohol-based solution that are cheap and very easily available. The anesthesia is easy and lidocaine works perfectly, but we have to know to be aware of the potential toxic effect of the lidocaine. You can do intraarticular injection of glucocorticoid. Usually there's no problem. And as we see, it takes roughly 1 year to do 40 and 50 biopsies and to reach 60% of overall proportion of gradable biopsies. I think that strict supervision at the beginning is really important because in my I would have preferred to have it, even if it's at the end it works also. It's can be tough when you're alone. Thank you.